Good morning once again. Thank you, Mr. Kumbula, for the kind introduction. So I'm going to be presenting on preeclampsia screening and prevention. I've come across Dr. S. Ngwenya. He has published several studies on preeclampsia and eclampsia in Bulawayo and how it has affected and how it is one of the leading causes of maternal mortality. And in one of his recommendations, he actually recommended that there should be increased preeclampsia screening and monitoring and the introduction of simplified risk stratification tools. So as an introduction, preeclampsia is hypertension in pregnancy that is accompanied by significant proteinuria or organ damage and affects about 2 to 5% of the pregnancies in some regions, and in Africa around 8 to 12%. And I think that was the prevalence he also saw in his study. So it also causes severe maternal-fetal complications, contributing to around 76,000 maternal deaths and 500,000 infant deaths annually. And we can all agree that's a lot. Of note that medical therapy that we actually give our patients when we see them, because initially they present late, it cannot stop disease progression. Because most of our patients then tend to say, I'm now on treatment, do I need to come back? So it doesn't stop disease progression. The only definitive treatment is delivery of the placenta. So early onset often forces preterm delivery, which is one of the most common causes of neonatal mortality. And these babies also suffer from cerebral palsy. So hence the prevention, not treatment, of preeclampsia has been a major subject of investigation over the decades, and is still ongoing. So several prediction models have been put forward by the American ECOG, FSOG, FMF model. We also have ones from Australia and New Zealand, but several systemic meta-analyses have all agreed that the FMF model has better predictive value in terms of preeclampsia screening. So it takes into priority the maternal risk, which has been discussed before, the biophysical markers, and biochemical markers. So we're going to discuss one-on-one, and we all agree, usually in our public hospitals, we are doing the maternal risk. But the maternal history, at the same time, are we doing it properly? So I'm going to start with the maternal history. So we all agree we have different boards of obstetrics and gynecology which practice differently. So we should respect what they think. So if what you call binary scoring, I'm going to talk about the NICE guideline, which is most quoted in most hospitals, where when we see our patients in ANC, we just take a history. Do they have a previous history of preeclampsia? Like we all know, for example, if a patient has early onset preeclampsia in the previous pregnancy, we know the risk of recurrence is around 33 to 50%. We just tend to give them aspirin. And when we give our patients aspirin, we tend to counsel our patient that we have a 62% reduction of early onset preeclampsia. And then other patients like chronic renal disease, chronic hypertension, type 1, type 2 DM, autoimmune disease. But then it then goes on to say, you also need 2 moderate risk factors. If you see a patient with 2 moderate risk factors, you should give them aspirin. But I don't think we are doing this in most of our clinics. We just tend to concentrate on the high risk factors and give them aspirin. And then history alone has a detection rate of about 40% and a false positive of about 10%. So our FMF model, it combines the MAP, maternal factors, uterine artery pulsatility index. I think you were shown yesterday how to do that, and serum PAPE and PGF at 11 to 13 weeks. So this has been discussed before. And then the mean arterial pressure, how do we take it? So from the history, this is measured by the sisters most of the time. So it has been seen that MAP is more useful than just a single reading of systolic and diastolic pressure. So how do you calculate MAP? So 2/3 diastolic pressure plus 1/3 systolic pressure. And in pregnancies that have preeclampsia, we know that MAP is increased. So you let your patient rest for about 5 minutes. You take 2 sets of measurements at 1 minute interval, and then you put into your FMF calculator. But then you should be careful because there are other sources of error. For example, if you have incorrect patient positioning, cuff application and size, or if the patient of talking, it has been seen to actually increase the MAP by about 6, or your full bladder. So this is the measurement of the MAP. Your patient is sitting upright with the back straight, and your arm cuff should be placed at the arm level as your heart, and then you relax your hand, or the patient is sitting comfortably on a chair, and then with your feet flat on the floor. So we should be careful about the cuff. I think we've seen most of the times that the cuff can actually affect the correct reading. So that was our MAP. And then we go on to uterine pulsatility index, which was demonstrated yesterday practically. So we see our patients, so what's the use of uterine artery Dopplers? So this has been explained before by Mr. Zanga, that is used in the examination of uterine artery in preeclampsia screening, and then it's high in pregnancies with impaired placentation, and it is associated with increased risk of developing preeclampsia. However, it has a detection rate of 26% for late onset preeclampsia and 48% in early onset preeclampsia. But the beauty of this thing is a simple, is a valuable evidence-based marker if it is in the correct hand and if it is done properly. So how do you perform the uterine artery pulsatility index? So you position your patient, and then you obtain a mid-sagittal section of the uterus and the cervix, as was demonstrated yesterday, and then you zoom your images and apply a color Doppler, and then you slide your transducer to view the paracervical region, and then you gently move the transducer from side to side to identify your uterine arteries. And then when you identify them at the level of the internal os, you then set your gate to 2 millimeters. This again was described in the morning. And then you set your angle of inclination about 30 degrees. So the peak systolic velocity should be more than 6 centimeters in the uterine artery. And then you obtain 3 similar consecutive waveforms. So you can do it transabdominally or transvaginal, depending on the gestation. So on the transvaginal approach, you're going to do it in an empty bladder. The patient is in the lithotomy position. Then you identify your uterine arteries at the level of the internal os. Remember your anatomy, the water under the bridge. It's about 2 centimeters from the internal os. And then you maintain your angle, less than 30 degrees, and then you record 3 waveforms. So the mean TVS tends to be slightly higher than the transabdominal, again because of the orientation and the anatomy of the uterine artery. So in the first trimester, which is between 11 and 13 weeks, you can use transabdominal or transvaginal, and the key reference about 2.35 for transabdominal and 3.1 for TV for transvaginal. And then the second trimester, transabdominal is actually preferred, and together again in the third trimester. And then we know that PI normally decreases with gestation. So a persistently high PI or notching actually implies poor placental remodeling. So this is just explanation again, as said in the morning, of the uterine pulsatility index. If it's less than 95th centile, it can be a normal finding. Then if it's high, then that's poor trophoblastic invasion. And early diastolic notch should be absent by 24 weeks. If it persists again, then you have high PE or FGR risk. And then if your PI is more than 9 centile, between 11 and 13 weeks, it detects 48% of early preeclampsia. And then you give your patient aspirin. So that was the uterine pulsatility index, which was demonstrated yesterday. So hopefully we're going to apply it in the next coming week. And then now we move on to biochemical markers, which continues to be a source of controversy in the low resource setting because of their prices. But the good thing nowadays, we are going to get rapid tests, which are available in other countries, around $20. So placental growth factor is synthesized by the placenta and is secreted by these trophoblastic cells. So it's part of the VEGF family, and we know it is potent angiogenic functions, and this one is cleaved by the S-fleet during the pathogenesis. So on its own, it has detection rate of 55% for early onset preeclampsia and a lower detection rate of 33% for late onset. And then our next marker is serum or S-fleet, which is an anti-angiogenic factor, which is again released due to hypoxia, due to abnormal placentation. So it's an anti-angiogenic factor which is involved in the pathogenesis of preeclampsia and is elevated in affected pregnancies. So rising maternal serum S-fleet levels may actually precede the onset of preeclampsia by 5 weeks. So it means you can actually predict the coming of preeclampsia 5 weeks prior. So it has limited value in first trimester screening, as it does not significantly improve prediction beyond the maternal risk factors alone. So it's also being used as a ratio like S-fleet PGF ratio in other countries where they use a cutoff of 38. So if they see a patient of hypertension, instead of just managing as the same, they do this S-fleet PGF ratio. If it's high, then you increase the surveillance of the patient. So this is just a table to show again the detection rate of these markers at early onset and late onset. So maternal factors on their own, around 52%, and MAP, if we add MAP, increases to 72%. MAP plus uterine pulsatility index, 96%. So in low results, we can actually use the maternal factors, MAP, and uterine pulsatility index with a detection rate of 96%. This does not really require most of the patient's money. But then we can see we cannot really predict late onset preeclampsia. So if it's high risk, then you tend to monitor more between 24 to 31 weeks. Sometimes you may need to do Dopplers more often. If it's low risk, the patient don't need to come as much often as the high risk patients. So we see the second and third trimester screening is not for intervention. You are just going to use it for risk stratifying your patient. They need to come early. Sometimes you need to give them max sulfate, steroids, depending on the values. So what's high risk is, this has been described before, the prior risk that's put in a calculator. If a patient is risk of more than 1 in 100, using the FMF model, then you know your patient is high risk. And this constitutes about 10% of the patient. And you treat this patient with aspirin if they're still less than 16 weeks. If more than 16 weeks, you just improve the surveillance rate. You need to see them more often. This is again just the image showing the test that you offer the patient, the maternal factors MAP, uterine pulsatility index, PGF, and the high risk, more surveillance, right? We reassess them every 2 weeks or every week. Low risk, they just join the normal. So what does FIGO say? We tend to use FIGO or WHO guidelines in the low resource setting. So it also supports that all pregnant women should be screened for preterm preeclampsia at 11 to 13 plus 6 weeks gestation, use a combination of maternal risk factors and biomarkers, not maternal factors only. Where there is resource limitation, routine screening for preterm preeclampsia by maternal risk factors, MAP should be completed. But we are also adding the Dopplers because we are saying ultrasound scan should be available to everyone. And if they are high risk, then we give them aspirin. And if it's post first trimester, increase surveillance. So what are the gaps? What are the sources of controversy? So the cost. So I'll just say what Dr. Ndaguri says. You don't need to calculate the patient's pockets. Don't assume they don't have money. We have patients who actually ask for all these tests, even in government hospital. So we should offer these patients all the tests as an obs-and-gyn, let them decide that it's expensive or not. Then what if these tests actually come down to around $20? We have to look at the cost versus cost effective. When these budgets are made, we look at cost effective, because preeclampsia, for example, is costing around thousands and billions of dollars. Imagine if a patient is admitted in ICU. If you are admitted in ICU today with preeclampsia, you might actually pay $5,000 per patient. So why not just use this money to prevent preeclampsia, prevent maternal mortality, and prevent neonatal mortality? Then after 20 weeks, screening is more about early diagnosis and triaging. I know many obstetricians want to say, if she's past first trimester, why bother screening? Why should we continue screening? So we know we've seen patients, even in labor ward, labor ward, you just see them, they're eclamptic, but if you look at their book, their BPs were kind of normal. So if we had used S-split, we could have predicted 4 weeks earlier this predicament. And then we also have patients, we also have health workers saying, why not just distribute aspirin to everyone instead of them paying for all these things? So there is no strong evidence that universal aspirin for all pregnant women sufficiently improves outcomes or reduce screening costs enough to justify routine treatment. We know our patients can hardly take ranferon for anemia. Why add another pill burden to them? So what's my conclusion? So preeclampsia screening should be part of routine T1NC and should be continued throughout pregnancy. Accurate preeclampsia prediction plus prophylaxis reduces adverse fetal maternal outcomes, and using only history is ineffective. We should include MAP, we should include biochemical markers, and it will make a difference, even in resource-limited settings. Thank you.